Okay, kia ora tātou, nau mai haere mai to our webinar on managing breastfeeding challenges. My name is Katie McCulloch. I'm a nurse practitioner who works in primary healthcare and for the Goodfellow Unit. Tonight we're going to be hearing from Dr. Sophie Mace. She's a GP specialising in maternal and infant care, particularly breastfeeding, sleep and infant mental health, as well as working as a rural GP in Motueka. She's the founder of Aotearoa Baby Clinic, a private clinic specialising in maternal and infant care. Sophie has done a postgraduate training in women's health, infant mental health, and she's accredited in neuroprotective developmental care and the POSSUMS approach. At policy level, she sits on the NMDHB and South Island Alliance Infant Mental Health Strategy Group and is a member of the Perinatal Anxiety and Depression Aotearoa Clinical Advisory Board. She's also on the Neuroprotective Developmental Care Education and Fellowship Committee. Sophie, we'll hand over to you now.
So kia ora koutou, ko Sophie Mace aho. So as Katie said, I'm a GP in Motueka. So I originally am from Nelson, grew up in Nelson, moved around the country and settled back here. So tonight we're going to talk about some of the basics of what GPs or primary care clinicians need to know about breastfeeding. So I've written GPs there, but obviously nurses, nurse practitioners and pharmacists as well. So who am I? I think Katie's done a pretty good introduction. So this is me, my husband and my two children. When I tried preparing for the talk, I did try and find a photo where Henry was wearing clothes, but I couldn't. So this was the best I could do. And just a note at the bottom that I will probably forget to talk about something. There's a lot to talk about in this area, and I've tried to squish it into an hour. So apologies if I forget something or if I don't cover something that you wanted to talk about. Feel free to flick me an email or ask in the Q&A and I'll try and cover it. So just really briefly tonight, what I wanted to talk about, just the introduction that we've done, some acknowledgements, some of the breastfeeding basics, the physiology, quick case study, and then some of the common infant feeding issues that we might see in GP land. So just firstly, I wanted to acknowledge a few things. One is that grief and trauma is really common in breastfeeding for mums and dads. So I just wanted to acknowledge that sometimes talking about breastfeeding and infant feeding can be really difficult for us as professionals, depending on our own personal relationship with breastfeeding or what has happened to someone in our whānau. So I just want to acknowledge that sometimes these sorts of talks can bring up some difficult thoughts and feelings. I also just wanted to touch briefly on the language used. In lots of my talks, I do use quite gendered language, and that's partly from an anatomical point of view in terms of using the word breast. And I do tend to use the word breastfeeding. In a clinical setting, obviously it's important to ask our patients what words they prefer. So chest feeding may be a common one that's used. I try and use non-gendered language as much as possible in terms of parents instead of just mothers or pregnant people rather than pregnant women necessarily. And in terms of conflict of interest, the only one that I have to declare is that I do have the private clinic. And I just wanted to make a point that I am, as far as I'm aware, compliant to the WHO code for infant feeding substitutes. So I don't have any conflict of interests with any companies that would be classed as non-code compliant. So some of the basics of the physiology more than the anatomy, which is partly because anatomy is not my strength. So if we take it right back to some of the early breast changes that we'd expect, breasts obviously develop during puberty, and then through each menstrual cycle, there is a change that happens through the breast. There's development of the ducts and then involution at the end of the cycle. During early pregnancy, the hormones cause some more breast development, and women do tend to notice a change in their breasts quite early. Some women, it might be before they even notice that they're pregnant. And then throughout pregnancy, later on in the third trimester, we get what's called lactogenesis 1. So that's when the breasts and the cells in the breast, the lactocytes, start to create colostrum, start to be able to make some of the early milk. which can be expressed during pregnancy. So antenatal expression of colostrum is something that can be really beneficial for some women. And just a note there in terms of breastfeeding while pregnant, because a lot of women are asking this, or a lot of parents are asking this, breastfeeding an older child while you are pregnant is perfectly safe. Milk production can go down and milk can taste different. So sometimes toddlers can get a little bit fussier, and some pregnant people can develop what's called a breastfeeding aversion when they're pregnant. So just a physical discomfort almost because of the with breastfeeding. So whether you're in the 3rd trimester, breasts have started developing colostrum, hopefully, may or may not be able to express that early milk. Lactogenesis 2 I've got on there is when the milk comes in. So when baby is born, the delivery of the placenta triggers further changes in the breast. So some of the cells in the breast, the lactocytes, the tight junctions close, and you get increase in volume of the milk, which usually happens a few days after delivery, sort of days 2 to 4. Delivery method and a few medical conditions for the pregnant person can delay lactogenesis too. So things like a cesarean section or a history of diabetes, either gestational diabetes or type 2 diabetes, can also delay the onset of lactogenesis 2 or milk coming in. So delivery method there obviously is quite important for women. Early skin to skin, regardless of delivery method, is really, really important for the breastfeeding relationship. So the more skin to skin in the early days, the more oxytocin is released, which is important for breastfeeding as well as for bonding and attachment. And oxytocin is released in both mum and baby's bodies. So we're then looking at the sort of early postpartum stages, and the frequent removal of milk is probably one of the most important concepts with breastfeeding, particularly in the early days. So the more often we can remove milk from the breasts, the more milk the breasts will produce. The more feeds in those early days, the more receptors are laid down on the breast, and the better it appears that long-term milk production is. So many of us in primary care won't really be involved at this stage, but midwives and hospital nurses are looking at ideally looking at the output of baby to making sure that baby is starting to switch from the meconium to the transitional stools to the sort of normal infant stools, and trying to do that for frequent removal of milk. Some babies in the early days find it difficult to latch or to remove milk themselves. So if a baby is unable to, if we're unable to get transfer of milk at the breast with the baby, or if there is separation of the parent, the breastfeeding parent and the baby, we really need to be thinking about how are we going to remove milk from the breast? How are we going to kind of get the ball rolling here? In the early days, that would often look like hand expression. The volumes expressed in the first couple of days of colostrum is very small. Babies will be having, a few mils up to 5 mils per feed, and pumps aren't really that efficient at getting small amounts out. So hand expression into a syringe or a spoon, which can then be fed to baby, can work really well. Normal and expected weight gain, most of you will know that it's relatively normal for babies to have an initial weight loss. A lot of the weight loss is to do with fluid loss and then basically just weeing it out, some diuresis. This is particularly the case if mum has had, the pregnant person has had IV fluids, so common in cesareans or augmented births or inductions with Synto, that she will have IV fluids. And you can then get an artificially high birth weight, which baby then wheezes out all the fluid, and then you can get more of a significant weight loss. So if you are seeing a baby who had quite a significant drop in the first sort of 24 hours, sometimes what we can do is actually look at the 24-hour weight and use that as the birth weight, and then use that to guide our monitoring, rather than sort of freaking out about a significant loss in that first time. Babies, breastfed babies should be regaining their birth weight within 1 to 2 weeks. And if there's a delay in that, or if there's a significant loss, then we really need to be looking at what's going on. So usually the trigger is about 10%. 10% weight loss doesn't necessarily mean needing to supplement, but it does mean that something needs to be looked at, and we need to assess the baby and the mum to see what's going on. Just wanted to mention here as well the importance of night feeds, particularly in those early days. Our society has a bit of an obsession with baby sleep, particularly overnight, but infants need to be feeding overnight, and they often feed quite frequently overnight. It is normal and it's expected, and it's a good thing. So feeding frequently overnight does appear to be protective against SUDI, as well as helping babies' growth and helping the breast milk production. I just wanted to talk a little bit at some point about this concept of breast milk storage capacity, or the available milk in a breast. This is a concept to do with how much milk a mother can store in the breasts before milk production starts dialing down. So when we're talking about frequent removal of milk, the more we remove milk from the breast, the more milk the breast will produce. If we are having long gaps between feeds, between removing milk from the breast, that can start telling the breasts to dial down the amount of milk that they're producing, which can cause significant issues later on. The amount of time between feeds where that starts to happen is very dependent on the mother. And it's a concept that most people refer to as breast milk storage capacity, but you can kind of think about it as how much available milk is there. So one woman might only have a smaller amount of milk available. That mother will then, or that baby will then probably have to feed more frequently than a mother who's able to have more milk readily available. And her baby might be able to go a little bit longer between feeds. So you can't tell what the available milk is like based on the breast size, which is frustrating, but just knowing that it is really dependent on the mum and the baby, how much milk is removed at a time, and therefore how frequently feeds might need to happen to maintain that milk production. Bottle feeding, I also just wanted to talk briefly about, and it might come up a little bit later as well. Bottle feeding is really, really common, and that might be using mum's express breast milk, it might be donor milk, or it might be formula. I find that most mums aren't, or most parents aren't taught, not many people talk to them about bottle feeding. And there are ways of bottle feeding in a way that is slightly more physiologically normal. And that allows the baby to have more control over the feed, which then can reduce issues later on, or reducing issues now with fussiness and reflux and things like that, and reducing accidental overfeeding. So I tend to refer to videos about what's called paste feeding, which I hope I've put a link to at the end, but I might not have. So even if you just Google paste bottle feeding and have a wee watch of a video and see what that looks like. Early postpartum, and then we're looking further on. So changes to feeds over time. After the first wee while, breast milk, the amount of milk that a baby needs to take stays relatively stable over time. The average is about 750 mils in a 24-hour period, give or take 100 or 200 mils. And that amount actually stays really stable for a long time, at least until solids are introduced. So unlike if you look at the back of a formula bottle tin, it says that the amounts need to increase over time. You don't need to do that for babies. The breast milk instead will change depending on their needs. Introducing solids here, the current recommendation is for solids to be, or complementary foods to be added in around about the age of 6 months and not earlier than 4 months. some babies and some whānau are looking at introducing complementary foods before 6 months and closer to 4 months. But I would tend to recommend more around the 6 month mark, tends to be a bit more when most babies are ready. And introducing solids, there's kind of two schools of thought. It can be a mixture of the two. There's the sort of puree and baby food concept, and then there's this concept of baby-led weaning. One might work better for a family than the other, or they might want to do a mixture of the two. The important thing is, again, we're wanting baby to have control over their own feeding as much as possible. So even if a family is doing spoon feeding or purees, baby needs to be involved in that in some way. So that might be holding the spoon, trying to get it to their mouth, missing, it goes over the shoulder, they're smushing it on their face, they're smushing it on the plate. That's very normal. If we're looking at something like baby-led weaning, which is when you're introducing more kind of not whole foods, but we're kind of sharing the family's food, and baby is feeding themselves. Again, that's going to be messy, on the face, on the plate, throwing it on the ground. Despite how many times you pick it up, they still throw it on the ground. This is all really important for their physical and cognitive development, to get that the feeling and the sensory enjoyment from food, and then starting to introduce it themselves. Babies will start by seeing if they can get it to their mouth. Then the next step is spitting it out. So the spitting it out, as annoying as it can be for parents, is really important. Then they start moving around in their mouth, and then they'll start swallowing. So there's this catchphrase that is food before one is just for fun. It's not quite true, because there are other aspects, but keeping in mind that the vast majority of a baby's caloric needs and nutritional needs will be coming from their milk, whether that's breast milk or formula. And so solids don't add a huge amount of calories at this stage. Iron is obviously an important one to get in, but we don't need to worry too much about the amount of solids that they're getting. And solids should never be a replacement for breast milk, i.e. I frequently hear stories where a baby might not be gaining weight very well, and the parents are told to introduce solids because then they'll get more calories in. And just remembering that the caloric density of breast milk and formula is much, much higher than of solids. So if there is weight plateaus or loss of weight, we need to be working out what else is going on. Returning to work in early childhood education, I won't go into the rest of this sort of stuff very much, but it's something that I frequently see, and it's something that you will probably see. What do I do when I go back to work? What am I going to do when they start daycare? And it's just having a think and having a discussion with parents about what that might look like, whether they're wanting to express, and if they are wanting to express milk, what that is going to look like, how that's going to happen. Is that hand expression? Is that hand pumps? Is that electric pumps? Talking about storage of breast milk, and I've got a link at the end for the Academy of Breastfeeding Medicine, who has a protocol or guidelines on storage of breast milk. So that's quite a good one to know. Tandem feeding here, just to say, totally normal, very common to feed 2 children at once. I mentioned earlier that breastfeeding while pregnant, and some parents will ask, if I'm feeding my toddler, what will the baby get? So the body is incredibly clever and will start making the colostrum for baby, and then toddler gets what's left over. Fertility here, it's very rare for a breastfeeding parent to need to wean to get pregnant again, like very rare. So I generally wouldn't recommend that a woman has to wean in order to have a baby again. It's normal to have a delay in periods coming back, and commonly around about 9 months. And if it's a lot later than that and she's struggling to get pregnant, we do need to start thinking about, could there be something else going on? Is there another reason for secondary amenorrhea? Natural age of weaning here is just that internationally the natural age of weaning is approximately 3 or 4. So very, very normal to be feeding toddlers up until that age, despite what the weird looks that some mums will get, unfortunately. So a bit of a case. This is a bit of a tricky one. There's lots of things to think about here, and this is actually not a very uncommon thing to see. So you guys will have these ones. You'll get tasks from nurses or admin that a mum has called in and she's asking for help because my baby cries all the time. So this case, so Sally is 33. She's going to bring in her 4-week-old baby Emma to see you. Sally had gestational diabetes and Emma was born at 40 plus 2 weeks via emergency Caesar for a failed induction. She said that it took a long time for her milk to come in, so it took about 6 days before she started to get a lot of milk. And Emma was given formula top-ups in the hospital from day one, and Sally was directed to triple feed in order to build up her production. So triple feeding is quite a common thing that I see women being asked to do, or that women are asked to do. It's basically breastfeed, give baby, so top up baby with a bottle either of express breast milk, donor milk, or formula, and then pump, and do that every 3 hours. As you can imagine, very difficult to do, especially if a breastfeed, if there's a cranky baby, a mum who's in a lot of pain, and not feeding very well. This can all take, like that might take an hour and a half, and then an hour and a half later they're starting again. So Sally in this case is managing about 6 or 7 pumps per 24 hours. She's finding it quite difficult to find the time to actually do it. So Sally has a history of anxiety and depression. She stopped her SSRI at 28 weeks because she was worried about the effect it might have on baby. Someone mentioned that baby might have withdrawals if she continues it through the 3rd trimester. Her partner is feeding Emma overnight with a bottle of formula so that Sally can get some sleep. Emma has reflux and is very spilly and cries if they try and put her down during the day. When Sally tries to feed, Emma is fussy and pulls off the breast, and Sally describes that breastfeeding really hurts. Both sides, it just bloody hurts. So this is one of those cases where I don't have an answer to what there is, because you'll probably notice there's a lot of things going on. So just as if I can go through here. So if we start from one of the most common things we see, it's pain with breastfeeding. Some women go into it thinking it's never going to hurt. Some women go into it being told that pain is normal and it's just to be expected. I would say that discomfort is normal. Pain in the first wee while and pain in the initial sort of 10 seconds of feeding can be normal initially, but other than that, pain is not normal. It is incredibly common, but it's not normal. So when I'm looking at or seeing somebody who has pain, the number one thing I'm wanting to look at is the fit and hold. So this is otherwise known as the latch or the positioning. So it's how are mum and baby fitting together at the breast? It's very common for there to be issues going on, and I don't think I even have my wee dolls to do a demonstration, which is a bit silly, but there's a lot of issues that can happen at the breast which causes the latch to be very shallow and then pain to happen because the nipple is sort of sitting too far forward in the mouth. This is one of those things where if you're interested in breastfeeding medicine and wanting to learn more, you can do so much good by learning more about fit and hold. I probably don't have time to go into it more at the moment, but I can answer questions later. But this is where you really want to have somebody who knows what they're doing with breastfeeding coming in, so like a good lactation consultant or someone similar, or a breastfeeding physician if you've got one around you. Blocked ducts, nipple blebs, mastitis, and abscesses. I'm going to talk about mastitis on the next page, and I'll leave blocked ducts for there, but all of these things can be really painful. Vasospasm is something that can happen in the nipples. It can be from a primary Raynaud's phenomenon, or it can also be a vasospasm secondary to trauma. And probably the second one, where it's secondary to poor fit and hold and trauma, is more common. But it presents similarly to what you'd expect with a vasospasm. So pain, like a burning deep pain in the nipple, which often radiates into the breast, and is often triggered by extremes of temperature. So when mum opens the fridge to get something out, she gets pain. So treatment for vasospasm is treating the underlying condition. So what's going on with the fit and hold? Is there nipple trauma happening? Is there damage to the nipple, like a crack that is being injured as baby feeds? In some cases, we can use calcium channel blockers like nifedipine. They do drop blood pressure, obviously, and lots of women postpartum don't have much blood pressure to spare. So just being really careful about that. I haven't found it particularly useful, but because generally the ones that I've been seeing have been to do with the fit and hold. Pump trauma is also pretty common. So this might be from the flanges, if a woman is pumping, the flanges being too big or too small. So ideally, the flange of a pump will be sort of 1 to 2 mils bigger than the nipple itself. If it's much too big, you'll get more of the breast and areola coming in and causing issues, and you can get edema at the base of the nipple. If it's too small, you can get friction and rubbing in the flange. So if a woman has a lot of pain and she's pumping, then just having a think about what else could be going on there, particularly if it's painful when she pumps, or if she has pain and she's exclusively pumping. Low production, I should say production or supply, and or poor weight gain. So hypolactation, where mum or the parent isn't able to make as much milk as baby needs, is very common, unfortunately. Having a true primary hypolactation is much less common, but it's very common to see more like an iatrogenic or a physiological low supply. So this might happen in, like our case with Sally, where she didn't have milk removed from the breast in the first couple of days, and then she's just not pumping often enough or feeding often enough for the breasts to recognize that they need to make more milk. Anatomical or other reasons why that might happen, things like polycystic ovarian syndrome or insulin resistance, there does seem to be an association with low milk production. It can happen in women who have had breast reduction surgery. So if they've had a lot of their breast, the glandular tissue removed, they don't have as much glandular tissue left, and they might not be able to make as much milk as baby is needing. And some women with a previous history of breast reduction, can also have issues with letdown itself. So they might initially make the milk, but the milk can't actually come out of the breasts, whether that's due to damage of the nerves or the ducts themselves. So that can cause a bit of an issue for some parents. There are other conditions like hypoplastic breasts, which is sort of an anatomical thing where women tend to have quite widely spaced breasts. There's a large gap often between the breasts, and the breast can look quite unusual. And this is often associated with lower milk production. And so, say if you're seeing a woman who has had a breast augmentation, it's good to know, why did she have the augmentation? Is it just because she was a B cup and she wanted to be a double D, or did her breasts look quite funny beforehand and she wanted them to look more quote unquote normal? It's something else we commonly see as well as a perceived low milk production. So in the postpartum period, women tend to, when the milk first comes in, they make more copious amounts of breast milk, and they can get a lot of fullness and a lot of engorgement. A lot of the engorgement is actually edema and fluid. But if the milk's not being removed frequently, they can get a lot of fullness. That settles down a bit. And then after sort of 4 to 6 weeks, and then I'll sometimes see it a bit later as well, the breasts tend to kind of regulate a little bit more and go, okay, let's just make the right amount for this baby. And women can notice that their breasts feel a lot softer, so they're not getting full as much. And sometimes babies can get a bit more efficient with their feeding, and so feeds are taking less time. So baby might only be feeding for 5 to 10 minutes, whereas before they feed for 30 minutes. And so women can start thinking, well, am I just not making enough milk? I must not be. And unless, you know, you kind of are able, or they are able to go through and work out, actually, baby's settled between feeds, weight gains are good, there's nothing else concerning going on, this is normal, what can happen is like what's called a top-up trap. So if mum thinks that she's not making enough milk, then she might offer a supplemental feed, whether that's again express milk or formula, which then means that baby is going to feed less frequently after that. She's going to then remove less milk, and you can kind of get this vicious cycle where it's actually the perceived low milk production is ending up causing low milk production. Perceived low milk production can also be a little bit of an early sign or a little bit of a red flag for postnatal anxiety or depression. So if a mum is really focused on the softness of the breasts and not being able to make enough, that can just be something sometimes to go in the back of your mind as something else going on. Obviously not always, because it is such a common thing to see anyway, but just one of those things that can make us think, do I just need to see this mum a bit more frequently? So in cases of low milk production, treatment options, obviously the number one thing we want to do is, if we can, increase mum's milk production. So looking at the fit and hold, is there anything that we can do to improve milk transfer at the breast? So improving or getting baby to be able to take more milk. If we can do that and we can increase the frequency of feeding, then that sometimes in itself can do the trick. Sometimes it might be, again, if we're thinking it's more of a perceived thing, it might be more like educating, talking to her, working through concerns, validating her feelings, following up just to see how things are going over time. If mum is definitely struggling to make enough milk for baby, and baby is hungry a lot of the time, if maybe the weight gains aren't what we'd expect, then we might be looking at supplemental feeds. So that again could be donor milk. A lot of the hospitals have got donor milk available in hospitals for preterm babies or early postpartum, and a lot of communities have kind of more casual breast banks or ways of getting donor milk on through Facebook pages, for example. Formula is obviously can be really, really beneficial and important. The types of formula, there's lots of different types of formula available in New Zealand. I won't talk too much about it, but the main things would be that we have really high standards of formula in New Zealand. So all of the ones that are available on the shelf will be safe. Anything that's marketed on top of that is just marketing. So if something has been seen to be really beneficial and needed in formula, then it will be in it, and it will be in all of the different ones. So any of the extra things that they advertise is marketing. What I've put here is SNS. So that is a way of giving a supplemental feed at the breast. And this is something that you can do with women if you've got the gear and you feel comfortable with it, or can refer to a lactation consultant who should be able to work this through and show mums how to do it. Pumping, I've got there, obviously, can be really beneficial if baby's not removing milk frequently enough, or maybe they're getting really tired on the breast. So a baby in the first couple of weeks who's falling asleep at the breast and not getting very much milk, then other than trying to improve things at the breast, which might be switching sides frequently, trying to encourage baby to feed more, then pumping can be added in just to, again, try and increase production. Domperidone is a medication that most of you will be familiar with. It's an anti-nausea, which helps with gastric emptying. It works on the dopamine receptor, so it increases prolactin levels. And in some women, it can be really, really beneficial to help with increasing milk production. Again, there's an Academy of Breastfeeding Medicine protocol on this sort of thing, and it's got a bit more information about domperidone, or I'm happy to talk about it. It doesn't work for everybody. It can cause some gastric upset in mum and baby. There have been concerns about cardiac issues with domperidone. So there was some case reports overseas of men receiving IV domperidone having arrhythmias. And that has sort of been extrapolated to the breastfeeding population. There, as far as I'm aware, and from last updates I've looked into, there has never been a case of dangerous arrhythmias in a breastfeeding mother taking domperidone. Pre-screening, you'd want to check if there's any history of arrhythmias for mum, if there's any family history of sudden cardiac death or anything suspicious for sudden cardiac deaths. An ECG can potentially be helpful, looking at things like long QT and not mixing it with other medications that can also prolong the QT, like the most common ones in this one would be some of the antibiotics and fluconazole. So just being aware of that. The evidence for a lot of things in breastfeeding medicine is not, there's not that much money in researching it, unfortunately, but for some women, they might only need a short-term course of domperidone. So that might be a mum who was breastfeeding well and then had something happen. So maybe she was admitted to hospital, she had an illness, baby was admitted to hospital, something's happened and she's had a reduction in her milk production. A short-term course of the domperidone can kind of boost production up to the point where she can then continue going with that supply and demand, and then she's able to wean it down. Other women who find it helpful seem to find that they need it for as long as they're breastfeeding for. So if they start weaning down, their production goes down and they notice it pretty quickly within a couple, within a day or a couple of days. So it's just really about counselling women about the risks, which do appear to be quite small, versus the risks of not taking it, which or not carrying it on, which might then mean earlier introduction of formula, which has its own risks. Hyperlactation, next one is another issue. So most frequently think of low milk supply as being a problem, but women who make too much milk can also have really big problems, and they often find it harder to kind of complain about it and be validated, because most women I know like this feel guilty about talking about it, because think of all those mums who aren't making enough. So hyperlactation, or producing more milk than baby, significantly more milk than baby needs, can look like a lot of a lot of fullness, discomfort in the breasts. It can look like recurrent mastitis or blockages. It can look like baby really struggling at the breast, spluttering and coughing and pulling off. And when they do, some mums are kind of spraying across the wall. It can cause some problems with baby's tummy. So this idea of functional lactose overload is not a lactose intolerance, but it's an issue with very large volumes of lactose and water passing through into the large intestine, being fermented by the gut bacteria in the large intestine of baby, creating gas, and can cause quite significant distension, so bloating of baby, as well as farting, explosive stools, and grisliness. And it can also cause babies to want to feed very frequently. So if they're getting larger volumes of lactose and water, they're not getting as much of the satiety chemicals from things like cholecystokinin from having the fat in the cream. And so they can want to feed very frequently. So sometimes you might also see like really significant weight gains, like 500 or 600 grams in a week sometimes. And that's just because they are hungry. So you wouldn't necessarily want to stop them feeding because they're hungry, but you want to be looking at ways to try and reduce that milk production to make things a bit more comfortable for mum and baby. So fit and hold, as always, the latch and positioning. So looking at the fit and hold in a way where baby has got more control over their feed, and they are able to pull away when they need to, and they have control over their breathing. The breathing suck swallow cycle is really, really important. More so than, you know, some people talk about it, if you feed lying down, it's gravity is going to stop the milk coming out. It's more that if we're in a more laid back position, baby can then have the control to pull back if they need to. So fit and hold is really important to help baby to manage that really high production. If they're pumping, trying to get them to stop it or reduce it. Obviously, we don't want to be telling the breasts to make more and more milk. So if she's getting very, very uncomfortable, sometimes just taking a little bit of the milk off to be comfortable, but certainly not removing a lot of milk. If she is pumping a lot of the time because she's at work or she's separated from baby or is exclusively pumping or for other reasons, then it might just look like reducing the amount of time she spent pumping or checking out the volumes and stopping once she's at a certain amount. So she's not just kind of pumping for as long as she possibly can to get the most milk out, because that's just going to ramp up that production. There are also then things like block feeding, which lots of you might have heard about. Block feeding needs to be managed quite closely because you can cause issues with tanking or mastitis in the other breast. So that's when getting a lactation consultant or someone involved if possible, if you're needing to look at something like that. Reflux is one we see really commonly in GP land. It's one that it seems to be less kind of popular out there compared to maybe 5 years ago. There's often kind of things that go around where that every issue that baby's having is blamed on. Reflux used to be really, really common, and colic and silent reflux. So physiological reflux is normal. So you'll all know that the gastroesophageal sphincter is relatively immature in a newborn baby, and milk can just kind of slosh up and down. So some degree of refluxate is really normal. It doesn't appear to hurt a baby. The milk buffers any acid for probably about 2 hours. So if a baby is being fed on cue, then it doesn't seem to be much of a problem. Reflux, other than causing a lot of washing, that sort of physiological reflux tends to peak and then ease off by about 4 months. Omeprazole PPIs are not indicated for reflux. There are concerns about increased risk of pneumonia, gastrointestinal disease, and allergies. And it also doesn't really make sense in terms of the physiology. It's not acid that's a problem in that case. If a baby has got, like, obviously, and just a plug for things like pyloric stenosis is obviously a different scenario when there's projectile vomiting. And if you're able to watch a feed and then look at baby's belly afterwards, sometimes you can see the pylorus. Different situation. That's not reflux. That's vomiting. A question to ask ourselves is if this reflux is quite significant, if it's going on for a long time, if there are other issues, particularly with the bowel, could it be allergy? So things like cow's milk protein allergy or food protein induced allergic proctocolitis, which is an inflammation of the bowel from food proteins, the most common being cow's milk, followed by soy, can cause a lot of reflux. Often these babies will be quite unsettled. They can have bowel problems, as in really loose bowels, sometimes quite mucousy stools, sometimes blood in the stools. Sometimes they can have really significant eczema. So if we're thinking there's actually a lot of different things going on here, could it actually be something like a cow's milk allergy? Then in a breastfeeding parent, we can talk about dairy exclusion. So if a breastfeeding mum can reduce or eliminate dairy from her own diet, then she's not going to be passing through those milk proteins into the breast milk, and that can allow baby's gut to heal. Generally, we would say it takes a trial. I would usually do a strict trial of about 2 weeks. It's not that it takes 2 weeks for the protein to get out of the milk, it's that it can take 2 weeks for baby's gut to heal. I recommend doing a relatively strict diet if you can, because that way you really know if it hasn't made a difference, it's not going to be that. It's not like you do 2 weeks of just cutting out most of it and then you then have to do 2 weeks more of really strict. There is about a 20% crossover where babies with cow's milk allergy will also have allergy to soy. So some parents will decide to cut both out at the same time. Generally, I would say try the cow's milk dairy first, and if there's been not much of a response or a partial response, then try soy. If you think that other food proteins might be associated with it, then that's when it would be time to get a lactation consultant, breastfeeding physician, or a dietitian involved, because it can get quite complicated and it can get tricky with mum's diet. There are also other allergies that can present in these babies, like FPIES, which is food protein-induced enterocolitis syndrome. So this happens when babies are exposed to a particular food protein. It's not an IgE-mediated allergy, and it causes quite severe vomiting. Baby looks really unwell, can be floppy, can be quite scary for parents. And if someone's thinking about FPIES, then again, pediatrician probably needs to be involved, and probably a dietitian. I've got there look at the relationship, but I'm not really going to have much time. This is more just that plug of that, the bidirectional relational health between mum and baby. So a mum who is really struggling and her sympathetic dial is switched up a lot of the time, baby can start picking up on that and can become fussier and crying more. And also vice versa. If a baby is crying a lot and is really difficult to settle, then that is going to inevitably impact on mum. So just looking at how that relationship's going, how each of them are managing. I'm going to have to try and stop there. I'll just try and flick through because I've got 10 minutes left. So mastitis, just really wanting to get across that mastitis is an inflammatory condition, which can have an infective element, but it's inflammatory at its core. So the thought, it's not a plumbing issue in terms of, often the thought is that you get a blocked duct, like there's maybe some thickened milk in a duct, and then that blocks it, and then you get that pressure of the milk, which hurt like a sty, you know, like it's not like a sty. It's not that you get a blockage in the duct, and then the milk builds up, and then that gets infected. And therefore, that, you know, the thought with that is that you have to massage the lump out, again, like a sty. Mastitis is more an inflammatory thing. So the thought is that milk stasis in the breast can cause some pressure, so increased pressure, and then some of the milk leaking into the interstitial tissue, which then causes an inflammatory response. That can have the impact of pressing on a duct and causing a bit of a blockage there, but also just sets up any, you know, like an inflammatory response like you'd have anywhere else. So there's pain, there's swelling, there can be redness. You can get systemic symptoms, so joint pains, aches, flu-like symptoms, fever, all of that sort of thing. If untreated, that can progress into an infective mastitis, so that area can be infected. And if an infective mastitis is left untreated, then that can form into an abscess, which needs further management. So mastitis, the biggest things are looking at why it's happened. So is it to do with hyperlactation? Is it mum's pumping at work and she, you know, hasn't been able to have a break, so she's not been able to pump? Is it that there's nipple trauma and there's been bacteria entering that way? So you can have sort of a primary infective thing. And don't ever massage a breast. So again, if we're thinking that it's a ductal blockage and we're trying to massage it out, you can cause quite a lot of tissue trauma to the breast, which can just exacerbate problems. So instead of thinking massaging a breast towards the nipple, we're thinking lymphatic drainage. You can get a lot of edema in a mastitic breast. And so lymphatic drainage towards the axilla can be really beneficial to try and remove some of that fluid. Continuing to feed on that side, obviously, because you don't want milk stasis. So you want baby to continue feeding. You want to be pumping on that side if baby's not feeding. And all of the antibiotics that we would use for mastitis, which is generally flucloxacillin, are safe for baby. Can cause a bit of gastric upset. Totally safe. keep feeding on that side. Tongue tie, lip tie, buckle ties. This seems to be the really popular thing at the moment. It's moved from reflux to tongue ties. So a classic tongue tie or ankylosing is a tight frenulum under the tongue. I've got a wee picture here. This was my second child. So you can see under the tongue there is a fold of mucosa, which is sitting quite far forward on the bottom of the tongue, which can restrict the tongue movement. They're relatively obvious if you look or have a feel. You can often see that baby doesn't have that much tongue movement. If you're thinking tongue tie, refer. So they need a really good breastfeeding assessment because they don't always cause problems with breastfeeding. If a baby's got a tie like this and ankylosing like this and there's no problems with breastfeeding, we don't need to do anything about it. We wouldn't recommend doing anything prophylactically. It just doesn't make, we just don't need to. If there's a problem with speech or anything like that later, which is not very common, we can deal with it later. Referring to someone who can do a good assessment, plus or minus, do a frenotomy, which is just snipping that thin bit of frenulum, can make a huge impact on breastfeeding. Not wanting to go. Lip ties are commonly talked about these days. This is a sort of frenulum just at the top between the upper gum and the lip. They're completely normal, so they occur in approximately 80% of babies. There's no evidence that they're pathological at all, or that they cause any problems with breastfeeding or speech. There's no evidence that cutting them will reduce the gap, the diathesis between the teeth. In fact, leaving them is probably better for the front teeth in the long run, as snipping it or lasering it can cause scarring, which can cause issues with the teeth. I don't know if we've got time to go into the posterior tongue tie thing, but if anybody's got any questions, let me know, because I could probably talk a wee bit about it, and I've only got 5 minutes left. Breast dermatology, so skin, think eczema. If there's a rash, think eczema. It's the most common thing. Again, a picture. DermNet's got some good pictures. Just think eczema. It's quite common. If mum has a history of eczema, even if she doesn't. If baby has recently started solids, what are they eating? Is there something that mum's allergic to that baby's then transferring onto the breast? And we treat it like any other eczema, with moisturizer and steroids if needed. And then if mum wants to, just wiping off the steroid before giving a feed, but not always needed. Eczema starts on the areola and moves onto the nipple. If you have eczema that's starting on the nipple and moving elsewhere, obviously if you want to get a scan for something like Paget's, that's when you think about it. But if it starts on the areola and moves onto the nipple, it's going to be eczema. Thrush on the breast or the nipple is very uncommon. It's again something that's talked about quite frequently, but it doesn't appear to have, there's not really any evidence behind nipple thrush. So treating nipples with thrush creams can cause eczema, and also doesn't tend to treat the underlying condition. So if it's eczema, it's not going to work, it can make it worse. If the pain is due to other things like anything else, then it's not necessarily dealing with the underlying problem. Medications and breastfeeding is a really big one. Long story short, most medications are fine. When we're thinking of medications and breastfeeding, we want to think of the pharmacodynamics and pharmacokinetics. Can the medication get into the maternal bloodstream? If it's there, can it get into the milk? If it's in the milk and baby, or will it stay in the milk? If baby drinks it, does it get into their blood supply? And if it does, will it harm them? So if you've got a medication that mum's taking orally, like simedicone, that's not absorbed, or like a local anesthetic, it's not absorbed into the bloodstream, there's no way it's going to get into the milk. Don't have to worry about it. If there's a medication that has like a thing of pharmacokinetics, really large medication is unlikely to get into the breast milk because it can't get through the cells. If mum is taking a medication that has to be injected, IV or IM, then that means that the bioavailability is really low. So even if baby swallows the milk, they're probably not going to absorb it into their body. And even after all of these ones, if it does get in and baby does absorb it, is it going to cause them harm? Is it a medication we give to babies anyway, like antibiotics, flucloxacillin, paracetamol, ibuprofen? It's not going to harm baby. And if we're thinking about what's the risk to the baby here, we need to consider the alternative. So we're not thinking as, because most medications, we're not giving medications to breastfeeding mums just for the sake of it. There's always an indication. And we have to consider the risk of not breastfeeding. So if you're telling a mum that she can't breastfeed with this medication, either she's not going to take the medication, which she might need. A really common one here would be antidepressants, or she's going to then have to switch to formula feeding, which has its own risks. So you're not thinking what's the risk of medication here, it's what is the risk of this medication versus the alternative. Pumping and dumping is not really necessary the vast majority of the time. There's a very small handful of medications that you might suggest this, but it's very small and they're not usually medications that we're using in general practice. Special mention there is alcohol. Alcohol passes into the breast milk easily, but it leaves the breast milk easily. So as long as that your milk's constantly being filtered, it's a living tissue. So if a mum drinks a glass of beer, by an hour or so, once your liver has gotten rid of it, it's going to be basically out of her breast milk. The highest concentration her breast milk can be would be equivalent to her blood alcohol percentage, because it doesn't go into the milk and just stay there, it kind of comes back out again. So the legal limit for driving in New Zealand is like 0.05, 0.08%. And that is the highest her breast milk concentration will be of alcohol. And it's probably going to be less because she's going to be filtering it. So the biggest issue with alcohol would be, is she so drunk that she can't look after her baby? And is she going to be co-sleeping? So parents who are bed sharing need to not be using alcohol or any other drugs or sedative medications. So if you're thinking of prescribing a sedative medication for a breastfeeding mum, talking to her, making sure she knows that she shouldn't be bed sharing in that situation. I think that is my hour. With medications, don't just make it up, look it up. I look up every time I prescribe for a breastfeeding mum, I look it up just to double check. New Zealand formulary isn't actually that bad. They changed what they use about a year ago, so it's not bad. But these are two additional ones. These are the ones that I use. On the left is an app called Infant Risk. It has a small charge to it, but it's quite easy to read. Like, it's just got the kind of pictures there. Yes, it's okay. No, it's not. The picture on the right is Medications in Mother's Milk, which is a textbook by Dr. Thomas Hale, and it's got a lot more information in it. So this can be really useful if you just want to know more about it. It's got more of the pharmacology in there. It talks more about the potential side effects for baby, and a bit more. It kind of goes into a lot more of the research that's been done. And some parents really like it when you look up a book because it looks better. So just remember, most medications are fine, and don't make it up, look it up. Don't have time to talk about any of this stuff. Sorry. And done. So I've just got here some useful resources just to plug the guidelines. The Academy of Breastfeeding Medicine is a really fantastic resource. It's an international academy of breastfeeding physicians. They've got a whole lot of protocols and guidelines. The medications one's there, some websites to look up if you're interested in learning more, and a couple of other useful websites. Okay, done.
Sophie, that was amazing. Thank you very much. And I wish we had a bit more time, because I think that particularly the mental health aspect would be quite a useful talk to have a conversation about, but maybe one that's directly related to that might be quite useful. So we do have quite a few questions coming through, and I guess I kind of would like just to focus on the medications, because you've literally just sort of directed us to some resources. There was a couple of questions regarding SSRIs in breastfeeding and what are the most, I guess, commonly used, or what ones do we prefer to use with breastfeeding?
Yep. So probably the most common one that would be used would be sertraline. So sertraline has the most evidence behind it. Basically all of them are going to be fine. You're not going to be using paroxetine purely because that's the one that's not safe in pregnancy, so we shouldn't be using that for women who might be getting pregnant. So sertraline is probably the most common, but the others like citalopram are also safe. There's sort of theoretical risks about jitteriness and things in infant, but it doesn't in infants. But if you talk to neonatologists, they don't tend to see withdrawal in infants really from SSRIs, and if a pregnant mum is using SSRIs, actually breastfeeding is going to reduce the risk of withdrawal symptoms in infants anyway. Some people would recommend not using fluoxetine because of the longer half-life. I think if mum has used something before and it's been beneficial, use that. If she knows what's worked for her, then you want to use the one that's going to work for her. If she hasn't tried any before, then I would maybe start with sertraline. And with the antidepressants in particular, remembering that we are comparing this to untreated depression or anxiety, which has really significant risks to maternal and infant health, infant physical and mental health. So it's not like you're saying what's the risk of antidepressants and breastfeeding versus nothing. It's antidepressants versus untreated mental illness. So yeah.
Awesome, thank you for that. And in terms of other medications like statins and things like that, any issues?
So statins have traditionally been contraindicated. I was listening to something the other day that suggested that smaller doses might be okay, but it will come down to a discussion about how long it's going to be and why she's on the statin, what are her overall risks if she were to come off it. Yeah.
And in terms of treating eczema on the nipples, you spoke about using steroids, and clearly steroids are absolutely fine if baby does, you put their mouth on the nipple afterwards, but what percentage of steroid would you use? Like, what's the strength?
I'd probably be using, depending on what it looks like, I'd probably be using triamcinolone or mometasone. My general, probably I'd go mometasone. My general rule with eczema is to kind of hit it hard and fast. So trying to treat it quickly rather than using a really weak one and you just have to kind of put up with it for ages. And ideally probably a cream rather than an ointment on the nipple, just for reducing the risk of the ointment base for baby. Yeah.
If the baby has oral thrush, use antifungal cream on the mother's nipples.
Can you, or do you?
Do we?
I don't tend to. Some mums want to, but I don't tend to. I tend to use my conazole gel for baby rather than Nilstat. Nilstat is not very effective, I've found, and my conazole gel for baby's mouth is a lot more effective. The main thing with it is you need to tell mums to apply it with a clean finger and put that in the mouth rather than it comes with a little spoon, and they should just throw the spoon out because there's been cases of a bolus of medication being.
Would it be useful to put it on the nipple as a delivery method for the baby getting it all in their mouth instead of putting it on their finger?
I think generally we'd do finger because, of course, now I can't remember all the details, but we generally wouldn't use the miconazole gel on the nipple. It'd be more, you'd be using a cream on the nipple and then the gel for baby.
Yeah, okay. Metronidazole, that old lovely tasting.
So metronidazole can apparently make the milk taste gross, but it is not contraindicated.
No. And would you recommend a stat dose over a week course, or?
Yeah, probably. Yeah.
Get it out of the way. And to dump the milk for 24 hours, or no? No,
don't need to. No. So the pumping and dumping, like as I said, is very, very rare that you would need to do that. And I'm right now again struggling to actually think of an example where you'd want to do that. Even things like, women are frequently told after a general anaesthetic that they'll have to pump and dump. But once a general anesthetics are, particularly when they're using gases, they're off gas really quickly. So by the time mum is awake and able to safely hold her baby, then most of the general anesthetic is gone. So she's actually safe to breastfeed as soon as she's awake. Same with things like radiology, so CT with contrasting MRIs, the vast majority are safe to breastfeed straight after. You don't need to pump and dump. There's actually a website called Trash the Pump and Dump, which goes into a bit more detail about the fact that it's actually not generally ever necessary. Yeah. There
you go. In terms of domperidone use and the doses that you would prescribe at, is there any recommended doses that you would, or is there an incidence of too much? Someone's here has mentioned that they've seen a patient on 4 tablets QID.
4 tablets QID. So that's a lot more than I would be using. So I would usually be going up to sort of 2 tablets 3 times a day. Slowly increasing. Sometimes you might go up to 4 times a day, but there doesn't seem to be much of a dose response between TDS and QID. I tend to get women to wean onto it. They should notice a difference between 24 to 48 hours. And you never want to stop it suddenly, because stopping it suddenly can cause anxiety. Some increased anxiety, which alongside concerns about milk production is not a good combination. So the Academy of Breastfeeding Medicine has a protocol on galactagogues, and that's got more dosing information for domperidone, as well as information about some of the other galactagogues parents might be using or asking about, like fenugreek or moringa and some of the herbal options.
Cool. In terms of reflux, how do you know if it's physiological reflux?
Yeah, good question. So looking at the overall picture, so like there's that concept of the happy chucker. So a baby who's generally kind of happy and content, they'll have a feed and they'll just it just comes out. It's like involuntary. It's not an effortful thing for them, which you compare to something more like vomiting, where it's a forceful ejection of milk. Is baby happy and settled most of the time? Are they really cranky, grizzly, upset, distressed more of the time? Of course, there's a lot of other things that can be contributing there, though. So like a baby who is bottle feeding, you want to be looking out for overfeeding, which is really, really common. So a lot of parents are being told to give, like 150 mils of a feed, which is a lot of volume for a baby, particularly a younger baby. So looking at, if they're bottle feeding, looking at the volumes and the frequencies, and going through that paced feeding stuff to ensure that baby's not taking more milk in, because then they're just going to bring it out. Looking at things like hyperlactation. So again, if baby's taking a lot of milk at the breast because mum's producing a lot, then they might be bringing some of that up. So it's sort of that overall picture. What is baby like other than, but still PPIs and things like ranitidine or famotidine are almost never indicated. A lot of the time it appears more and more that if you are looking at more of a pathological reflux, or like a GORD or reflux type thing, then actually that is a symptom of something else, possibly an allergy, rather than a pathology of itself, if that makes sense.
Yeah. Okay. Yep. And in terms of I guess when you'd be concerned and things like that about those babies who are spilling all the time, you are looking at the whole picture, aren't you? So you're not just, okay. And what do
you're looking at the whole picture, and also how distressed is the parent?
Yeah.
Because that, like if the parent is distressed, you can't just go, oh, it's normal, don't worry about it. Like regardless of what is actually going on for baby, you can't do that. She's not going to believe you. And that's not going to deal with the problem. So that's where, like, if you do have a good lactation consultant or a breastfeeding physician around to refer to, can be really, really useful too. Like these sorts of things would take, like I'm spending probably 45-minute consults as an initial consult for these. So these are really, really hard 15-minute consults.
Yeah.
Yeah.
And someone was asking how to refer to lactation consultants and things like that. And I know that Health Pathways should have resources.
Yep. So it depends on where you are, and it depends on what resources you have. Unfortunately, we don't have enough around the country, and some regions have like very few or none. So it really depends on where you are, but Health Pathways should have that information, or your PHO or the maternity unit at the DHB should know. There is also the New Zealand lactation consultant group. There's a list of many of the IBCLCs, the board certified lactation consultants, and you can search that page. Plunkett also has an online, like a Zoom free lactation consultant you can book into.
Awesome.
Yeah.
And of course, people can refer to your clinic as well.
So there's a few of us sort of breastfeeding physicians around. So in Auckland, we've got Yvonne Lafort, who is kind of our godmother, matriarch here. So thank you, Yvonne, for all that you do for us. So Yvonne, Hamilton, Tauranga, Christchurch, Wellington and Palmerston North, and Nelson Motueka. So most of us do Zoom as well as in person if you're needing somebody seen or someone wants to be seen.
Yvonne has been being very helpful on the questions tonight, so thanks, Yvonne. She's given some good links. So would you recommend any other supplements for breastfeeding women other than iodine?
Recommendation would be for vitamin D. That would be for women who are breastfeeding through the winter months, or all women. Those are probably the main things, and just ensuring that she's getting a relatively good diet, that she's eating enough, drinking enough. Yeah. Okay.
Someone was asking about how you do lymphatic drainage when you don't want to be doing massage on the mat.
No, so there is on the Physician's Guide to Breastfeeding website, which is Dr. Katrina Mitchell in the States. She's got a little handout that you can get, but I generally otherwise will tell women it's the type of pressure that you would use to stroke a cat or to stroke your baby's head on the breast from the nipple towards the axilla. So it's very, very gentle. Yeah. Sometimes physios or OTs can do that as well. So some of them will do mastitis care.
Okay.
Yeah.
If baby is constipated, can they be given water on top of breast milk?
I wouldn't. I'd be more asking, why is baby constipated? A breastfed baby generally shouldn't be constipated. In the early weeks, that would imply that they're maybe not getting enough milk. There's not getting enough calories in input. And constipation in a breastfed baby can also sometimes be associated with cow's milk protein allergy. So I'd want to be thinking, why are they constipated? A mum breastfeeding will provide all the water that babies need. So like in summer when it's really hot, babies will usually feed more frequently just to get more water. So babies shouldn't need water, and that can risk, particularly if they're not having solids, that can risk hyponatremia. So wouldn't recommend it.
Cool. And in terms of goat's milk for use, and when people are concerned that there is a lactose
or a cow's milk allergy, the proteins are really similar. So usually if baby's reacting to the cow's milk protein, they'll react to the goat's milk. So if parents are wanting to supplement with formula, then you'd probably be looking at one of the prescribed ones. At the moment, there is a shortage in the prescribed ones, which is pretty scary. So if we can help parents to continue breastfeeding and do this sort of exclusions instead, that's going to be a lot safer. But generally you'd be looking at the prescribable ones, which GPs can prescribe on special authority up until the age of 1. Yeah.
Someone was just really quickly requesting that you do speak about the posterior tongue tie.
Okay. So, I don't know how much I can say about. I guess long story short is that there's no anatomical evidence that a posterior tongue tie is a thing or causes problems. So when you are looking at the fit and the hold, we're looking at both the mum and the baby. So how are they fitting together? When a baby is breastfeeding, they take the breast tissue into their mouth, and ideally that breast tissue will fill the oral cavity. The tongue's job is to cup the breast tissue and kind of help stabilize it in the mouth. The nipple will ideally be up at the junction between the hard and the soft palate, where it's kind of just free. It's not compressed by the hard palate. That's why it should come out looking like a nipple instead of compressed. So if there's anything that will impact on the amount of breast tissue a baby is able to take into their mouth, that can cause a shallower latch and compression of the nipple, which can cause pain, fussiness from the baby, pulling off frequently, sometimes low milk transfer. Most of the time, that is to do with the kind of biodynamics of the feed itself. There are anatomical things for baby as well. So if mum's got a very, very delicate breast, or not very kind of, very low elasticity, it can be harder for baby to draw that breast tissue into their mouth. If baby has got a very high palate, or an anatomical reason why they have more oral cavity to fill, then you can imagine if a mum's got generous breasts and lots of breast tissue to get into the mouth, that's not going to cause an issue. But if you can combine those two, you can have then issues with where the tongue needs to kind of come up more than it might in another situation. So I don't know if I'm kind of getting to the point here, but there's some great work done by Nikki Mills, who's ENT surgeon, who was Starship, she's now Nelson. So if you're interested in it, she's done anatomical work as well as MRI studies, which kind of goes into this, and she's got a fantastic diagram of what is actually going on in the floor of the mouth. So a ankylosing that we'd normally see is a fold of mucosa. You can then get sometimes a fold of mucosa that has a bit of fascia in it, and then you can get a fold of mucosa that has muscle tissue in it. So that's possibly what people are talking about with posterior tie. The theory that they give is that there's a band of, like a tight physical band of tissue that's causing a restriction of the tongue, which has not been found to be the case. But say if you've got an issue where you've got a bit of tongue coming up, and I don't know how to describe it, sorry. But sometimes you can just get a little bit of an issue where the mum and the baby don't quite fit fully. If someone were to go and cut that fascia or muscle layer, you might get more movement of the tongue. You might not, and that might improve things at the breast, it might not. Generally, that's more of a sort of anatomical variant, and you can almost always actually improve things without doing anything about them.
Right.
Hopefully that ranty answer kind of.
Good. And unfortunately, that is all we have time for tonight. There are a few more questions, so I have to just reiterate, I do apologize that we weren't able to get through everybody. You are an incredibly awesome, dynamic speaker, Sophie, and I really appreciated everything you had tonight. So, and just taking the time to present to us, it's a really, as you said, there's not much funding that goes into breastfeeding medicine. So to have your expertise on this has been really valuable. I just want to thank everyone who's joined us tonight as well. So take care, everybody. Thank you for joining us tonight. And thank you again, Sophie.
Thank you, Katie. Thanks, everybody. Ka kite.